this first half of the cycle, and it's signaling that follicle development to happen. And then, so it's increasing throughout this phase. And then LH, or luteinizing hormone. Some of you might be familiar with that because that's the one that surges and increases significantly right before ovulation and helps stimulate that signal for ovulation to happen. So that's the one that you're actually picking up on ovulation predictor kits, for example. It's picking up the luteinizing hormone. So after it's done what it needs to and it's peaked, it's going to drop right back down again. So in terms of the other hormones, so estrogen is secreted by all these small follicles, or the cells in the follicles. And so estrogen is going to be increasing in the first half of the cycle as well. Whereas progesterone, it's not going to be secreted until after ovulation. So you can see it's rising here, and it's what's secreted by the corpus luteum. So you can see progesterone rises in approximately 7 days after ovulation, and in this textbook period, 7 days before period comes is when we get the peak of our progesterone. And it's actually as these hormones, estrogen and progesterone, go back down, that's what gives the signal for the lining of the endometrium, the lining of the uterus, to actually shed when it's not needed anymore if a pregnancy doesn't occur. So then we're back here at the start where day 1 is first day of bleeding. You have your menstrual cycle. So down at the bottom is showing what happens with the endometrium. So you can see the lining is thickening, and that's because of the estrogen increasing. It continues to increase into that luteal phase, and then as the hormones drop away, that signals that lining to shed. So in terms of a normal cycle, like I was saying, textbook 28 days, but in general, it can vary by a few days as long as it's coming fairly monthly. So irregular cycles, we would classify if someone's cycles either are becoming too frequently. So if it's coming less than every 21 days, so that's from first day of bleeding to the next time you have bleeding. More commonly, what we see is where it's longer, so more than 35 days, we start to feel is more abnormal, that either the recruitment for ovulation to happen is really delayed, or someone might not be ovulating at all, and they may have, months where they're not getting any bleed. In terms of fertility apps and tracking, certainly there is a ton on the market now. So these are basically trying to help patients predict what is that fertile window. And so if you're trying to get pregnant, they're hopefully going to try to help you time intercourse, or if you're doing inseminations, for example, with donor sperm, what is that optimal window of when you should be trying? When should sperm and egg be meeting? And so basically what they're doing is you'd entering, I'm sure lots of you have used these, but basically you're putting in your period dates, and it collects that data, and it's just averaging out your periods. And then it minuses 14 days. And it does that because the luteal phase, that second half, is what is very standard. That typically does not change. If you ovulate, it's going to be 14 days usually, around, give or take a day. It's the first phase, that follicular phase, that is more variable. And so it minuses 14 days from the average, and it tries to give you a general window. That's going to work okay for people that cycles vary by a few days, because it usually gives a window, and it says, from day 10 to day 20, try every other day. But for people whose cycles are unpredictable, so 1 month, it's 28 days, the next month it's 37, and then it's 45, it's not, when it minuses that 14 days, it's not going to predict what's going to happen next cycle for ovulation. So really you kind of get left with, in terms of trying, if you want to get pregnant, going back to just our usual recommendations of trying every other day, so that if you do ovulate, the sperm's been where it needs to be at the right time. So it does get harder. Certainly these apps can still be helpful. I remember back in the day, like med student days, where patients would have printed off, monthly calendars and colored in pictures of periods. So it certainly, as a physician, makes it easier because, someone just hands me a phone and I can see an entire summary of a month or a year of their monthly cycles. So for tracking and not having to, do too much work for recording it, it does help for physicians to review. So they do still have a role, but it's certainly harder for predicting when to try. So in terms of potential causes for irregular cycles, and so when we're talking about these potential causes, we're really looking at it sort of more from a system or almost anatomical approach. And so when we do that, we're looking at what's called the HPO axis. And so H is the hypothalamus. So that's sort of the top structure in the brain. The P is the pituitary, so the next structure down, that's releasing the FSH and the LH, and then the ovaries. And those are what are really involved in this ovulation system. And then also obviously the uterus and cervix are involved with bleeding as well. And so they can sort of be related to irregular cycles. But in terms of ovulation, we'll focus on that HPO axis. And so anything that's going to potentially suppress the hypothalamus. So it's secreting hormones that stimulate hormone release from the pituitary. So anything that's going to suppress that is going to shut down the whole system. So that, for example, could be weight issues. So really low body fat, sometimes associated with eating disorders. It's shutting down that hypothalamic signaling to the rest of the body to have ovulation and fertility sort of be an option. Similarly, excessive exercise, particularly in people that are high level competition, strenuous exercise, and really what that threshold is for exercise for an individual can vary, interestingly. So excessive exercise can do that as well. Other things like really quite significant stresses, so death in the family, war, things like that. Significant stresses we know can also impact that system, as well as serious illness. So when you're sort of in an unwell state, that can sometimes shut down that whole reproductive system. At the pituitary level, so there's also hormones that are secreted that have to do with thyroid regulation, another hormone called prolactin that's usually involved with breast milk secretion. If those become abnormal, that's going to feed back to that system again, and can sometimes feed back and decrease that FSH and LH. So thyroid issues, elevated prolactin, if they're not controlled. So hypothyroid or hyperthyroid can impact cycles and ovulation as well. And then at the ovary level, so although rare, there can be a situation which is called premature ovarian insufficiency, or POI. And that's where, so females are basically born with a certain follicular pool, and over time that unfortunately decreases. And so the natural age for menopause, for example, would be around age 51, and that follicle pool has really just almost completely diminished. And so someone's no longer ovulating, the ovary can't respond anymore to those reproductive hormones. But once in a while, what happens is that happens faster, and so typically POI is if someone is less than age 40 and this follicle pool has depleted much faster than typical. And there can be multiple different reasons for that to happen, and often even unexplained. So certainly we're learning more about that. But in that situation at the ovary level, it's not able to respond. So the FSH and the LH from the brain are trying, and they're signaling the ovary as much as they can, and the ovary just doesn't have that follicle pool anymore to respond and ovulate. So that FSH and LH are going to be really high because they're working so hard to try to stimulate the ovary. So whereas that's uncommon, PCOS is the other. PCOS, people sometimes refer to it as, is a very common, what we sort of classify as an ovarian cause as well. And that would be probably the most common reason I would see that people have irregular cycles. And so PCOS is actually quite complex in terms of its interplay. It involves some factors sort of from the brain and the ovary and the periphery as well, and some related to adiposity. And so I'll talk a little bit more about that. But basically with PCOS, what's happening is there isn't as much as an FSH stimulation to the follicles. So they're not able to have that dominant follicle recruitment and that ovulation release. And then at the uterus level, so obviously we need a healthy endometrium to indicate that ovulation has happened if pregnancy doesn't occur, because it's the decreasing hormones and then the shedding of that endometrium that gives us the signal that the lining has shed. And so if something's injured that endometrium, for example, procedures to the uterus that have caused scarring and decreased growth of that endometrium. Although your body may still be ovulating and this sort of hormone cascade is working, you're not going to see that because you're not having the bleed to indicate that that has happened. So sometimes people won't have periods at all or very infrequent sort of light bleeding with that. Or it may be there's something structural, like once in a while polyps or fibroids can cause bleeding in between cycles, and you don't really know which part of the bleeding is the normal hormone cycle versus which is from that little polyp or fibroid. So once in a while that can throw sort of your tracking of cycles off as well as sometimes things at the cervix level. So certainly making sure there's no masses, or sometimes if there's an infection that can irritate that cervical tissue, and that can cause abnormal bleeding as well. So like I mentioned, polycystic ovary syndrome is definitely the most common thing that an REI would probably see for irregular cycles. And so it's this syndrome that has certain features that we see kind of together. And so the most common being those irregular cycles. So more often with PCOS, it's that cycles are more than 35 days or skipping months at a time. Other features can sometimes be increased evidence of androgens or testosterone type hormones. And so that may be clinical signs where patients may have problems with increased hair growth, upper lip, chin, abdomen, dark hair growth, problems with acne or thinning hair. Or sometimes we actually just see it in blood work when we do the testing. We might see it in the hormone levels when we do it. And then also, as you can see in the picture here, so that's an ultrasound of an ovary. With PCOS, it's actually a misnomer. It's not actually large cysts in the ovary. It's actually just lots of small follicles, sometimes in that sort of peripheral pattern that you can see here, but it's usually seeing like over 20 follicles in an ovary. So that can be another feature that we would pick up on ultrasound that help indicate this is more of the cause. And then also we always are making sure we've ruled out other causes like thyroid or prolactin related hormones instead, because they can look similar to polycystic ovary syndrome. So this other slide that I have here, basically I'm not going to go through this, but this is just to emphasize how complex that PCOS system is. And we don't truly know exactly what the underlying mechanism or inciting event is for PCOS. And partly that's because it's so all intertwined with each other. But essentially with PCOS, what's happening is we will be seeing an increased LH output and a decreased FSH. And so that ratio is often different. We'll also see, like I said, increased androgen output, and that is partly related to that LH and FSH ratio. And that can be from the ovary or other sort of organs that are involved with androgen production. As well, there's a component of insulin, and so increased insulin or decreased insulin resistance that's going to sort of perpetuate some of these aspects as well. And these are all interconnected. Often with PCOS, and we certainly see sort of different, what we call phenotypes, but often we will see increased weight associated with PCOS. And so with increased adiposity, we also have increased estrogen levels, because fat or adiposity is also going to secrete estrogen peripherally. And that's important because that impacts how PCOS can sometimes present. And so ultimately, you're going to have decreased FSH, and so you're not getting that follicle stimulation and that ovulation to occur. However, you're still having in your body increased estrogen levels from this increased potential adiposity. And so the endometrium, or the lining of the uterus, is still seeing that higher estrogen levels. So the lining is still going to be building up. And it's not going to have the hormone signal from ovulation. And so you're not having that endometrium stabilized by progesterone. And so because there's no progesterone, the uterus never sees that withdrawal and has this nice sort of organized withdrawal bleed that we see with a menstrual cycle, where you sort of get on average, 5 days of bleeding. Instead, what happens is that estrogen's increasing, the lining's increasing, and eventually it just starts to shed sort of more irregular, a little more sporadic, and can be ongoing bleeding. So that's why it becomes important with polycystic ovary syndrome to make sure at whatever life stage someone's at, that they also have endometrial protection. So that it's just not ongoing increasing estrogen. So when fertility is not a sort of concern or desire, often people will be on something that's going to protect the lining that has progesterone in it, so birth control pills, a progesterone IUD. If fertility is desired, though, then we sort of have to switch gears and figure out a way to hopefully get someone to ovulate so they can try to get pregnant. But if we still haven't achieved that, we also need to make sure we're protecting the lining of the uterus. So we'll often be giving patients cyclic progesterone, so 10 days of progesterone, so that they still get that stabilization and get a withdrawal bleed so that their lining is protected. So in terms of accessing healthcare, if you do have irregular cycles, and so I've included a picture here you can see of, more of our current COVID situation with telehealth. So certainly I do know that most fertility clinics across the country are still offering consultation to the best of our abilities through telehealth. But really with irregular cycles, I do still think that family doctors, GPs are your first line resource. And this is because they definitely can still initiate those tests that are going to help try to figure out what that underlying cause is. Often, depending on what the cause is, they're going to actually be able to initiate treatments to help improve cycles. And also, even more importantly, because some of these causes have other underlying health issues, they're in a position to sort of ensure ongoing optimization of your health for some of these other issues. So I think it is important that they're still involved first line. Depending on their comfort level and what the underlying cause is, appropriate referrals, it may be that you've seen an endocrinologist or referred to an endocrinologist, so particularly if it's more of a thyroid or a prolactin issue. Or sometimes if someone's had PCOS or premature ovarian insufficiency and fertility hasn't been a desire, sort of a concern at that point, a lot of patients may have seen endocrinologists in the past for management of those issues. But as soon as fertility and desire for pregnancy becomes more important, you do want to start sort of moving towards seeing an REI or fertility doctor to assist with this. And when that should occur is going to vary. So it's going to depend a little bit on your family doctor's comfort and experience with irregular cycles and what the specific causes and the treatments that are available for that. It's going to depend on local wait times to see a fertility doctor. And it's also potentially going to depend a little bit on whether your doctor has identified any other risk factors for having problems getting pregnant. So, for example, other tubal issues or sperm issues, because certainly it's one thing to fix an ovulation issue, but if the tubes also are potentially blocked, then the approach would have been much different by a fertility doctor. So typically all of those things sort of should be taken into account for referral timing. So just to sort of briefly touch on some of the treatments that can be helpful for irregular cycles, particularly in the setting of wanting to get pregnant. So if it's something at that brain level, so the hypothalamic pituitary level, then really focusing on what the underlying cause potentially is if it's hypothalamic. So it may be if body fat has been low and is potentially the issue, optimizing weight and body fat in a healthy way, decreasing exercise levels, optimizing health if you have had systemic issues and getting those under control with your doctor that's helping with that. If it's endocrine issues, so ensuring good disease control of thyroid or prolactin. So typically with thyroid, it's if it's hypothyroid, usually we see cycles more irregular and longer, whereas with hyperthyroid, sometimes periods become more frequent or lighter. And so when it's true thyroid disease and that's corrected, we often do see those cycles go right back to being more regular again with good ovulation. However, there is also fertility treatments that can give synthetically those FSH and LH hormones as injections that will still help to stimulate that ovulation reproductive system to sort of kick in again. But that would require, because they're injection medications, they require close monitoring during that stimulation part. And so that would require referral to a fertility REI physician to help monitor that. At the ovary level, so with polycystic ovary syndrome, we do know that some lifestyle optimization, so if weight is increased, we do know sometimes even with 5-10% decrease in weight, or even just increased exercise levels, that sometimes can help the ovulation resume. So sometimes even lifestyle can improve things significantly. However, there's also oral ovulation medications that a patient can take for 5 days that sort of help trick the brain into not seeing that estrogen feedback from the periphery and secrete more of an FSH stimulation to get ovulation to happen. Because there's also this insulin resistance often associated with PCOS, sometimes diabetes-related medications like metformin can have a role. They're not as good as ovulation medications, but sometimes they can help assist with sort of kicking in that ovulation signaling again as well. And once in a while, those oral ovulation medications still aren't enough to get that reproductive cascade to happen, even at their maximum dose. So there is sometimes a role for the same FSH injection medications, either to get sort of single ovulation to happen, or sometimes just moving to IVF so that we get lots of eggs to grow and making it an efficient process. So lots of different potential options with PCOS. With premature ovarian insufficiency, unfortunately, things are more limited. There's nothing we have that regenerates eggs and follicle pool. So although there's a small chance still of sort of random ovulation, and patients may still get pregnant on their own, it's pretty low. And so most of the time, the treatment that we can offer is donor egg, either known donor, or there are donor egg banks now, or exploring sort of big picture options for family planning like adoption. So I think I'll leave it there, and then I'll sort of hand things over to Carolyn and see if we've had questions coming in or anything else, Carolyn, that you think I should go over.
Yeah, for sure. Thank you so much. Oh, thanks for sharing that photo, Nikki. That's for those of you who don't know, this is your Fertility Matters Canada Board of Directors, and the image we've pulled together for CIAW 2020. So Nikki, I don't know, do you want to stop sharing your slides, and then you and I can have, so your face comes up in a larger video for people as you're answering their questions?
Sure, yeah.
Yeah, that's all right. There you go. Perfect. So we do have quite a few questions actually that came in, so this is awesome. From Facebook, I've been told I had a slim ovarian reserve. How is that possible when being on the pill for a long time and not ovulating for 14 years?
Oh, that's a great question. So the difficult thing is, even being on the birth control pill, it doesn't actually preserve that follicular pool. And the reason is so basically every month there's still going to be, like I said, there's those 10 follicles that are going to be recruited, and it's really the signal for one dominant follicle to grow that causes ovulation. So the birth control pill is going to shut down that single follicle recruitment and ovulation, but that pool that started and whatever trees, that's still going to disappear and go away. So that is not preserved. It's just preventing dominant follicle growth. So the birth control pill wouldn't have preserved that. Similarly, when we do an IVF cycle, I often get the question, is that going to decrease my sort of long-term fertility because we're recruiting more eggs? And it's the same thing. We're just utilizing that pool, that sort of 10 follicles that would have been there, and we're actually tricking them into all developing into dominant follicles. So you would have lost that pool anyway. So we're not depleting the pool any faster with IVF either.
Oh, that's really interesting. I didn't realize that. So that's really, thank you for that answer. Another question from Facebook. I sometimes have bleeding around day 20 to 24, more than just spotting. Does that end my cycle, or is that mid-cycle bleeding? This makes it so hard to track when I'm fertile. I have finished reserves, not PCOS, if that makes a difference. Does that make sense? Finished reserves? Might be a typo.
So I mean, certainly it's always hard because I don't know all information, but in general, sometimes we see, I'll talk about kind of different phases of mid-cycle bleeding. And so if it's lighter bleeding than your normal menstrual cycle, it can either be sometimes mid-cycle, and once in a while, that's because someone's body just happens to notice that little dip in estrogen that happens. And it doesn't not necessarily mean there's something structural or something wrong. You've actually ovulated and the body just notices. You might have a little bit of mid-cycle bleeding post-ovulation. Because hers sounds like it's a little bit later in the cycle, sometimes that sort of luteal bleeding, or if it's spotting pre going into your cycle, once in a while that can indicate something. Like sometimes elevated prolactin might cause that. So certainly if you hadn't seen a doctor, it'd be good to just sort of make sure there's nothing endocrine that could be impacting. Having said that, if it's truly lighter bleeding and it's spotting, that can be very common leading into a cycle. And that's just because that estrogen and progesterone, as you saw in my graph, it doesn't sort of go from elevated to zero and the uterus see that all at once. It was sort of a steady decline. So some people's body will start to see the decline, start to spot until it goes into its, oh, those hormones are gone, and have a full bleed. And so there can be sort of different, you know, sort of nuances to people's own menstrual cycles. It does, if it's heavier bleeding, it does make that tracking harder. So in general, if someone's cycles, you know, they're getting their sort of crampy feeling and all those what we call meliminal symptoms at, you know, a month apart, they just get bleeding in the middle, it would still be helpful around that kind of day 14 or mid-cycle to be the window that you want to be trying in.
Another question, this one is, I have PCOS and have spotting or light bleeding for 10 days prior to the beginning of my cycle. Is this normal? Cycle has been around 40 days.
So it depends a little bit on how much, but I do always worry in someone with PCOS when their cycles are already that prolonged, 40 days, that it indicates still a good ovulation is not happening. And it's at a minimum taken a while to get that ovulation to happen. So I would predict if they were to be on something or ovulation was to be optimized, either medications or lifestyle or whatever it may be, and those cycles got closer to 30 days with a normal sort of recruitment pattern, I would suspect that spotting may actually decrease and they'd have a more synchronized bleed.
Okay. Some more coming. They're just coming fast and furious. I also have diminished reserve. I have light 1 day bleeding. Would that count as a cycle? I haven't had a cycle in months.
No, probably not. It's hard with sort of 1 day of light bleeding in the situation of very minimal. So it's also hard because, like I was mentioning, with even premature ovarian insufficiency, sometimes people will ovulate and they'll never get a bleed. And that's just because it was only one cycle that the uterus saw estrogen. It wasn't enough to build it up to get that sort of withdrawal shed. And so that's why there's still a chance they get pregnant. They didn't even have a period. On the other side, sometimes people will have bleeding and it's not actually related to ovulation. And that's where the situation with PCOS, where it just, you know, finally sheds very irregularly. So certainly with decreased ovarian reserve, it's hard because it depends on where sort of in the degree of decreased reserve someone is. But in the sort of situation of cycles being quite absent and 1 day of bleeding, I would be worried whether that was an ovulation or not signal.
Okay. So that person should probably have a discussion with their family doctor or a reproductive specialist.
Yeah.
I have multiple follicles on my ovaries with irregular cycles suggesting PCOS. However, my blood work was all normal. What should I do now?
So basically, if someone has irregular cycles and they've sort of met what we have a criteria for PCOS, and so it's not dependent just on blood work. So if someone's seen them, sort of diagnosed them with PCOS because of the other things, and they're not having regular ovulatory cycles, they do want to see a physician to help optimize the ovulation.
Okay. Can one go from having regular periods and ovulation for years and then have them stop being regular?
Yes, definitely. Again, it depends. Did something new happen? Did something new endocrine change? You know, thyroid disease could start up. There's lots of different causes that they might have been regular before and now irregular. With polycystic ovary syndrome, we often see that it is more lifelong history, but not always. And certainly, I will often see where when someone's weight starts to increase over sort of life time, sometimes that does correlate with their cycles getting more irregular. And so I do see that commonly.
Okay. So what I'm hearing is sometimes there's lots of opportunities here for women to have discussions with their physicians. Do you recommend they start with their family physician? Is this something that they should take to an OB/GYN? How do they kind of navigate that, or what should they be considering?
Yeah, so like I mentioned before, I do think sort of starting point would be a family doctor, just because it's helpful that they initiate those tests so that they potentially know what the underlying cause is. Now, based on their comfort level, for example, they may not be comfortable giving you an absolute diagnosis of PCOS, but they would have done all those other hormones so that when you see a gynecologist or an REI, they know it's not premature ovarian insufficiency. It's a little bit faster to sort of get into the meat of it and help someone with treatments. So I do think first line should be seeing a family doctor. But you're right, I didn't mention general gynecologists, but they're also going to be very comfortable at helping people manage PCOS and other potential causes.
Great. Thank you for that. I have PCOS and blood tests have shown higher LH. Is there any point in using at-home OPKs? I really just want to see if I'm ovulating without medication after some major lifestyle changes.
So that's a great question because often with PCOS, that LH may be high enough that it's constantly picked up. So it sometimes just means doing a little bit of sort of a test or experiment. And so typically, if someone starts doing those around day 10, cycles have been a little bit more regular, they get a clear negative on their OPK, negative, and then a clear positive. That's quite a good indicator that you have picked it up, particularly if the cycles are regular and about 14 days after that, you have bleeding. However, if you start doing those OPKs and you're just like, oh gosh, every day is positive or it's faintly positive, then they're probably not working and you're picking up false positives from your high LH.
Great. How does decreased ovarian reserve impact someone's cycle? And is there anything that you can do to treat that?
So decreased reserve is always a tricky one. So ovarian reserve is basically sort of tests that we would do that look at follicle number, hormone levels, anti-Müllerian hormone, AMH, you might have heard of. And so with decreased ovarian reserve, again, it's that follicle pool has depleted more quickly than a typical time. What's important is that it doesn't necessarily predict chance for pregnancy. So it's something we sort of do as fertility doctors to get an idea of ovarian reserve. But sometimes it does end up correlating with decreased cycle length. And that's because as the ovarian reserve decreases, that follicular recruitment starts to happen actually a little bit faster. And so we sometimes do start to see a shortening of cycles. So someone, for example, may have used to always been, 30 days and now it's decreased to 26 days. So there can be other causes for that, but typically is what we would see with decreased ovarian reserve. And so it's hard. There's no treatment, again, that's going to, replenish that pool. So often if you're with a fertility clinic or you're seeing general gynecologists, the one thing to keep in mind is that ovarian reserve is very predictive of how someone's going to respond to an IVF cycle when we actually give the hormones and stimulate. How many eggs can we anticipate getting? And so sometimes people with decreased ovarian reserve are going to consider moving moving through fertility treatments a little bit faster and more aggressively than someone that has normal ovarian reserve. So in terms of treatment, that would be sort of the one thing that I would suggest for weighing.
Awesome. We hear a lot in our support groups. I use the term a lot, that might be a dangerous word, but we do hear of younger females with decreased ovarian reserve. If you were having a conversation with, a millennial, they might not actually be thinking about starting a family. They might not be, at a stage in their life where having a family, they might not be in a relationship. They might not even know if they want a family. Are there questions that patients should consider, or younger women should consider, or things they should be talking to with their GP about their reproductive health, where some of these things may be caught or come to the forefront earlier in their life and not at a time when they're actually actively trying to get pregnant?
So I think you're kind of touching on a few issues. And so certainly in the example you gave with decreased ovarian reserve at a younger age. And so again, I think it's really important to go back to, study after study so far has not shown a high correlation between decreased ovarian reserve and chance that someone's going to get pregnant and their fertility potential. That is back to age and the quality of the egg, and that's very different. So decreased ovarian reserve really is just getting at how likely is a stimulation going to go well. And so if someone's not in a position where they want to get pregnant or going to pursue fertility treatments, if we test for ovarian reserve, it's hard. Is that going to change? Is that going to cause undue anxiety? And what does it really tell them that's important to them? Like, how likely is it I'm going to have a baby? So it's hard. We don't really have any markers that predict future fertility, really. So ovarian reserve, I do think, has a little bit more of a role now that I'm seeing patients for the potential for fertility preservation.
Okay.
And so sometimes it's really hard to decide when to do that. And certainly, again, age being more of an important factor for how likely that's going to be a sort of backup plan for reproduction in the future. But sometimes when people are a little bit more on the fence, sort of not sure if they want to do it, if we saw that their ovarian reserve is decreased, they may feel more strongly about moving forward with fertility preservation earlier, because it's more likely when we stimulate, we'll have a good number of eggs from that. Okay. So if we do fertility preservation, we're usually hoping to have, at least kind of 12, 15 eggs from one cycle to freeze, just to, keep it efficient and increase the chances are helpful in the future. Whereas if someone has decreased reserve and you do an IVF stimulation, we only get, 5 eggs. Then that's a hard situation. And so ovarian reserve will potentially help predict that response.
Okay. Are there at what age should a woman, I'm just thinking of this younger generation, when should women, or what are the conversations they should be having, not necessarily about ovarian reserve, but just about fertility health in general? What would you recommend for someone or the conversation? How do you start that conversation with your physician?
Well, I think you've already mentioned sort of age and obviously the importance of age, but it still needs to be right timing for an individual. But I think education, and I think things have improved around education on age for females being such an important factor. But also, I think earlier on addressing some of the lifestyle things that can also affect fertility. So we know smoking can affect, it actually can also decrease ovarian reserve a little bit faster. So addressing those things, weight, optimizing to a healthy weight prior to being in the situation where you want to get pregnant, and in general, sort of optimized health for other health conditions. So for example, when someone has diabetes, it's really optimal that that's already controlled far prior to the time that they want to get pregnant. So again, it needs to be individualized, and that's where sort of I think family doctors also have a good role to play with that.
Yeah, that's really important. I feel like I talk to women a lot who may not have ever had this conversation with their doctor. So I think it's important to just for you to mention those things for people to say, yeah, those are things that maybe I should address earlier instead of when we're looking to start our family. We do have a couple of more questions. I think we have a little bit more time. Would AMH of 27 be an indicator of PCO for a 37-year-old female?
So AMH is quite a difficult topic. The reason being, a number is really hard to interpret because it's been through a lot of different assays, so just how it was tested, and there's also different units, and so I can sort of assume that those are probably right now if it was recently done, what units that would be in. But having said, and so that would be sort of a elevated or normal AMH in picomoles per liter. However, we still don't have enough data that AMH has been incorporated into diagnosis for PCOS. And there were recently, I guess about a year and a half ago, some European guidelines that had reviewed everything with PCOS, really sort of comprehensive guidelines that came out, and they still didn't feel like the data was strong enough to have a cutoff with AMH. And partly it's because of that difficult history we've had with them and all the different assays and not having specific nomograms yet to have a cutoff for diagnosis.
Okay, great. Thank you for that. We've got one more question here. In the past, I've had irregular cycles and many PCOS symptoms when I was younger. And through treatment, I was told I had polycystic ovaries. But due to regular cycles at that time, I did not have PCOS. Is there a connection between PCOS and polycystic ovaries, or are they two completely different things? I also have endometriosis, and I'm not sure if that makes a difference.
So I'll just start. Endometriosis, PCOS would be two different things. In terms of PCOS, so seeing polycystic, what we refer to as polycystic ovaries, so seeing lots of follicles in the ovary on ultrasound is just one potential criteria we would look at for helping diagnose PCOS. However, we do know that lots of people will have a really good follicle count on ultrasound and not have any of the other features of PCOS. So typically the criteria that we use is what's called the Rotterdam criteria in North America, where we want to see 2 out of 3 criteria. So irregular cycles, something that indicates increased androgens, whether that's in lab tests or clinically, or seeing polycystic ovaries on ultrasound. So if someone has, lots of follicles when they have their ultrasound done, but they've not had irregular cycles and they don't have any of those evidence of increased androgens, we typically would not classify that as polycystic ovary syndrome.
Okay, that's really helpful. I didn't know the difference between the two, so thank you for that. One more, we've got one here, and then we'll probably we might have time for one more after that. The fertility medications to grow follicles and prompt ovulation did seem to be working for my cycle. Now that the clinics are closed or not starting new treatment cycles, what would you suggest we do to help with PCOS and long cycles during this time? And just as an aside, I'm not overweight and already exercise regularly.
So she's already addressed one of the important factors. So yes, sometimes lifestyle is, but in the absence of that being an issue, are already optimized. So I guess it depends on the clinics and our unique situation right now. But certainly we, in our organization at RFP here in Calgary, we're still doing phone consults and we're still helping people with ovulation medications so that we can keep them ovulating and keep their cycles regular so they can still try on their own at home. So if it's beyond those ovulation medications working and someone's had to move on to injection medications, then certainly things are going to be more optimized. But I think we're all sort of hopeful and optimistic that we're going to be able to move forward sometime in the near future with fertility treatments where it needs to be done in clinic in a safe way, though.
Great, thank you. And I did have one actually come in prior to the session. It's the last one we'll do. Which med for PCOS should I use, Letrozole or Clomid?
So that can be sometimes difficult, and that is a discussion that you'd want to have either with your, GP, gynecologist, and fertility physician. Certainly letrozole, or Femara, some people might know it by, is off-label. It was never designed for fertility purposes. It's actually medication to decrease breast cancer. But it works very well at getting people to ovulate. And so in that big European guideline I was mentioning, they do recommend letrozole as first line for people specifically with PCOS. And that's because there was quite a large, good trial that showed a higher chance of ovulation and ultimately baby over the clomiphene or Clomid that we had used for so long. So they both work very well, but letrozole, because it's off-label, does require discussion about some of those sort of things to be aware of. And certainly we always want patients to do home pregnancy tests before they start it, just to avoid any chance someone's pregnant when they take it by accident. Clomiphene also has become a little bit tricky because it's no longer manufactured by the company that used to make it. So it's compounded. So its availability is also changing. So it's almost good that we have both available potentially, depending on someone's specific circumstances.
Great. Thank you so much. That's a lot of information. I'm sure the people who are watching, and based on the questions coming in, people were feeling, comfortable asking questions, and I'm thrilled that you were here to answer them for all of us. Do you have anything you'd like to say? Like in closing, do you have any words of wisdom?
No, I don't think so, but mostly just everybody stay, safe and healthy at this time, and yeah.
Great. Well, Nikki, thank you so much for your time today. We really appreciate it. And for everybody who's been tuning in today and all of our sessions this week, don't forget it's Canadian Infertility Awareness Week. We've got live sessions all week long. Tune into our Facebook page for all of the events, for fertilitymatters.ca/FMC events for a listing of all of the events you can attend virtually from the comfort of your own home. And as a last little note for everybody, Fertility Matters Canada actually does have a website, fertility quiz. Sorry, the words were escaping me. And it lives on our website at fertilitymatters.ca/quiz. So for people who may be questioning if they have an issue with their fertility, or whether they should be speaking to someone about their fertility health, you can find that quiz, take it, it's 8 questions, and it will let you know if maybe it's time to start speaking to a fertility specialist. So Nikki, thank you. I appreciate it. Thank you everybody for tuning in, and we will see you live again tomorrow. Bye.
Bye.